Rheoviridae family. I just told you that the Rheoviridae family had something called Colorado tick fever, which was the arthropod bone. But I'm not talking about the arthropod bone one. I'm talking about the other member of the family, and that is rotavirus. And I think everything about rotavirus I have already discussed with you guys. I'll quickly repeat it. What do you need to know about rotavirus? Rotavirus causes, number one, I'll write it again. I told you it is like a rotating wheel. So if someone asks you what is the shape of this virus for the diagnosis, the shape of this virus is going to be a, or just not rotating wheel, just learn it as a wheel. The shape of this virus is going to be a wheel. And why did I say rota? Because there is a rota hua bachcha. Why rota hua bachcha? Because that kid is having diarrhea. This is the most common cause of diarrhea in children. So it is a rota hua bachcha. Diarrhea hoga. Rota hua bachcha mein diarrhea hoga. So this is the only double-stranded RNA virus. The only double-stranded RNA virus. All these points I have taught you in your general virology. So please note, the diarrhea wala kid is gonna be the double-stranded RNA virus. Rota hua, why rota? Because he's actually having diarrhea. And rotating wheel will tell you the shape. Now, someone's having diarrhea. How do you think there's going to be transmission? The transmission is going to be feco-oral. And what do you think is going to be the toxin? Something to do with the intestine, enterotoxin. The name of that toxin is NSP4. So NSP4 is an enterotoxin, and that causes this disease. How do you think you're going to do the diagnosis? Ma'am, diarrhea ka case hai, to stool sample is what you'll take. Antigen detection karoge, that is also settled, and you will do PCR. Common sense diagnosis is there, nothing fancy. But vaccine questions aata hai, that comes in pediatrics. What are the vaccines for rotavirus that you have to consider? There is Rotatec, there is Rotarix, Rota se to I will learn. These are the rotavirus vaccines. But is there any side effect of these vaccines that they ask you? Think from pediatrics. What is the side effect? Intussusception is a very famous question that you get. See, intussusception is, as it is a very famous topic in pediatrics, but because I teach you path and micro, let me tell you two intussusception questions which will always haunt you somewhere or the other. So related to intussusception, the question that you get, so I'll write intussusception over here. Related to intussusception, number one question that you get in microbiology, it is a side effect of the rotavirus vaccine. And in pathology, do you know which question do you get? One polyp can cause intussusception. This is associated with Peutz-Jeghers polyp. PJP, Peutz-Jeghers polyps, can also cause intussusception. These are the two integrated questions of path and micro for intussusception that you will integrate with pediatrics and medicine. Okay, so this is also done. Rheoviridae family ho gaya. Now we come down to Filoviridae family or the filovirus. So filovirus mein what are we going to have? We are going to have something called the Marburg virus. Marburg virus causes a lot of hemorrhage and fever. So it is going to be the hemorrhagic fever. Not many questions come on it. But one question of Ebola virus which came up in Africa is very essential. What do you already know about Ebola virus? Ebola virus looks filamentous like this. Or I had learned that Ebola virus is going to be like a bowl of spaghetti pasta. It is like a bowl of spaghetti pasta. So in other words, it is going to be filamentous in nature. How is it going to spread? The spread of Ebola virus is going to be by secretion and contact. So let me just show you a life cycle first. In the life cycle, I can see a bat because I realize that bat is going to be the reservoir host. I will see a bat over here. Dekho, dhyan rakhna. Have I taught you in the same segment of virology bat somewhere else? I had taught you fruit bat. Fruit bat was for Nipah virus. This is just a bat. Along with the bat, I can see that the wild animals are also affected, and that is how it's coming to humans. So how is it coming to the humans? Either we have come in contact with a bat or we have come in contact with some wild animals. So number one, we can either come in contact with a bat or we can come in contact with a wild animal, but human to human transmission over here is known. Human to human transmission is also known for Ebola virus. That is why Ebola virus is being said to be so deadly, because even from patient to patient, that is why I said, na, how is the transmission occurring? It is occurring by secretions and contact. So patient to patient is also there. Where did you not have any patient to patient? Remember, Kaisanur forest disease, wo sirf forest se aayega, either from a tick or it was coming from the monkey fever, but it was not human to human. Here, it can come from a bat, it can come from the monkey, or any wild animal, but it can also come from human to human. That is Ebola virus. Now, Ebola has a lot of strains. So remember, the Zaire Ebola, Ivory Coast, and Reston. So please note that Zaire Ebola is most virulent. So Zaire Ebola is going to be very, very virulent. Ivory Coast is the least virulent, and Reston is resting variant. वो rest कर रहा है. That is not causing any disease. Reston is not going to cause any disease. If you can learn the incubation period, it is between 3 to 15 days. Not very important, I would say, but this is important. The Zaire is going to be very, very deadly. ठीक है? So I have learned Zaire is zabardast. It is going to cause maximum virulence, and Reston is resting. It is not going to cause any disease in humans. If I tell you the latest medicine questions of Ebola virus, please note that Ebola के लिए there is actually a monoclonal antibody that has come up, or a drug that has come up, and that is what you need to know for Ebola, and that is Inmazeb. Inmazeb is actually a trio of monoclonal antibodies that you have, even if you don't know the names of these, but yeah, Inmazeb is the drug name. 3 monoclonal antibodies which is being used for the treatment, and also we have a vaccine now, and that vaccine comes before obviously the most zabardast wala virus strain, that is the Zaire vaccine. Yeah, so there's a vaccine also that has been developed. I hope everyone's okay. We finished off all the arboviruses, alongside which we have also finished off all the very, very important different miscellaneous filovirus, reovirus, that is settled. Now we are just left with 2 viruses. One is going to be the retrovirus, matlab HIV, and the other one is going to be the coronavirus. So let's get going. Now we talk about retrovirus. Actually, we always learn retrovirus as HIV, but HIV actually, apart from that, there's another retrovirus called HTLV. Although I have taught you HTLV in pathology fully, I will give you quick salient features here. But pehle, let me talk about the most important one, and that is HIV. Now, when I talk about HIV, please note, if I ask you, what is in terms of India mein sabse common, abroad mein sabse common, so please note, when we are talking about HIV, it is HIV-1 that is going to be very, very important. It is going to be group M, and it is going to be the serotype C, which is very, very common in India. It is the serotype C, which is very, very common in India. So remember, HIV-1 group M, serotype C, is the one that we encounter most commonly in our country. But of course, we encounter HIV-2 also. So whenever you say that, ma'am, HIV ka test ho raha hai, we test for HIV-1 and HIV-2. Okay, the testing is for both, but HIV-1 is more common. And Ratlo, group M, serotype C is common in our country. Now for HIV, we always know the structure of this virus is very, very important. If you go very carefully, these are all the structural genes, right? So the structural genes tells me that there is, first I'll highlight the genes. There is a GAG gene, there is a Pol gene, and then there is an envelope protein. Let me start with envelope. Envelope has GP, envelope ka pura naam hai GP160. 160 I have divided into GP120, and instead of exact 40, 41, okay? So GP120, which is the one that you see coming on the surface, and GP41, which you see going through the membrane, right? So 120 is going to be the surface wala, and 41 is going to be the transmembrane one. That makes up GP160. Now, when we talk about the GAG gene, if you look at GAG gene, I will write P6, P7, then 17, then 24. How do you learn it? 6, 7, 17, 24. Repeat with me. 6, 7, 17 and 24, out of which P24 testing is very, very important. Whenever you get questions on needle stick injury, kya testing karoge? P24 testing karenge. That is what I'll come to you in a while. These all come under GAG. You don't have to learn which one is present where. You just need to know P6, 7, 17 and 24. Coming to the Pol. So Pol mein you will learn RIP. There are 3 RIP enzymes. R for reverse transcriptase, which you need to know is RIP at the age of what? Reverse transcriptase, RIP at the age of 66, okay? I is going to stand for integrase, and P is going to stand for protease. You don't have to learn their P values. Repeating once again, reverse transcriptase, integrase and protease, out of which reverse transcriptase RIP kaun se age mein hua? 66 pe hua. So these are all the structural proteins. I'm repeating once again. The envelope has GP160. 160 is divided into 2 parts. There is 120 and 41. GAG has 4 things, 6, 7, 17 and 24. Coming to Paul, Paul has 3 enzymes, that is RIP. Now let's see if this HIV enters into our body, how will it attach and where will it attach? Either it can attach to the CD4 T cells or it can attach to the macrophages. So now you think, ma'am, attachment to common sense hai. It is this GP 120 and 41 that will come and attach. वो surface पर है, so that is what will come and attach. Exactly. So for the attachment, we have GP 120 and GP 41 that will be used, but single attachment does not work. You will realize other than that, there is also a co-binding. Something else also binds. And what does it come and bind to? It's just not going to bind to the CD4 T cells. No, it is also going to bind to something called CXCR4 and CCR5. ये क्या लग रहा है? Have you read about it? Try to think. CXC, CC. Yes, ma'am, I have read this somewhere, but in pathology, these are chemokine receptors. So basically, I realize that for the HIV to bind, only single just going and sitting on a CD4 T cell will not work. सिर्फ ऐसे CD4 पे जाके बैठ जाओ, that is not going to happen. It will need to do some extra effort, and that is it will have to bind to the chemokine receptors also, that is CXCR4 and CCR5. So now let's imagine that this is come into the system. Now finally the binding is complete, fusion will occur and the virus is going to enter us. If the virus enters us, what is going to be the entire timeline that we are going to consider over here? So first and foremost, if you look on the y-axis, we have the CD4 count. Normal CD4 count is much above 1000, around 1500 or so. So starting में तो the CD4 count is going to be over there. But ma'am, starting में the virus is going to be, initially the virus is going to of course be 0. So you have two graphs going on over here. This graph is telling you, the blue color graph is basically telling you about the CD4 count. Whereas this red color graph is going to tell you about the HIV virus. So starting में virus तो 0 है and CD4 count अपना 1500 के आसपास, very very good. In the initial infection, what you call as acute HIV syndrome, where patient will have fever, muscle ache, myalgia, arthralgia, lymphadenopathy, basic fever wala symptoms, I realized that gradually the CD4's count has started going down, right? Why? Because the HIV virus has started coming up. So HIV virus body में multiply कर रहा है. The HIV is multiplying in the body. That is why the CD4 count is going down. That is what happens in the acute HIV syndrome. After that, I realized suddenly the virus has started decreasing and my CD4 count has started improving. Why? Because your body is trying to fight. ऐसे थोड़ी that some virus will come and you will not do anything. Your body is trying to fight. So your CD4 count starts improving and the virus amount starts going down and the patient suddenly becomes free of symptoms or totally fine. Clinical latency. Remember, clinically patient is looking fine, but if you do test for microbiology HIV testing, that is not latent. There is no microbiology latency that is noted. Matlab the testing done at this phase will still come out to be positive. It is only a clinical latency, not a microbiological latency. Okay, after that, once this phase is over, and this phase can go on for even up till 10 years, then comes a phase of constitutional symptoms, and then the patient is going to have opportunistic infection. So now the next question that comes is, which is going to be quite a deadly table, and I'm sorry for it, but what are the opportunistic infections that you have to know for HIV? The opportunistic infection is going to depend on the CD4 count. So see, there is no end of learning this table, but at least I can tell you what are the most expected questions. Less than 500 mein what they have to ask you is going to be tuberculosis. Must know question. Less than 200 mein what they are definitely going to ask you is pneumocystis, gerovecine pneumonia, their favorite question of path medicine micro. Less than 200. In less than 100, they have to ask you about the cerebral toxoplasmosis, cryptococcal meningitis, cryptosporidiosis, even CMV can be seen. So, sorry, CCC things are coming. What did I say? Cerebral toxoplasmosis, cryptococcal meningitis, cryptosporidiosis, and CMV can also be there. But please remember, less than 50. Less than 50, CMV, chorioretinitis, and MAC infections are the most common. Repeating, less than 50, CMV, chorioretinitis, and MAC infection. So repeating, TB. So I want you to focus on the lungs wala finding. Less than 500 में TB होगा. Less than 200, तो very very important. There is going to be pneumocystis jirovecii. Less than 100, all the CCC things are there. CMV, retinitis, and MAC infections are going to be less than 50. In fact, if I try to note all the lung related things, you'll say, ma'am, lung में pneumonia क्यों होगा? Either there's a TB वाला problem, or there's a streptococcus pneumonia, pneumococcus wala problem, or there's a pneumocystis carinii pneumonia. These are the three problems. Either it's a bacteria that is TB, or it is a bacteria that is streptococcus pneumoniae, or it is a fungus that is pneumocystis carinii. So I just told you that TB will occur at CD4 count less than 500. Even streptococcus pneumonia occurs at a CD4 count less than 500. So bacterial infections under 500 hota hai, but pneumocystis carinii is going to occur at a CD4 count less than 200. So first thing that you look out in the paper is the CD4 count. Then you'll see what is the radiology given. We all know streptococcus pneumonia. जो pneumonia होता है, that involves an entire lobe, that is lobar consolidation. For TB, I think everyone knows there's a very famous snowstorm or hazy appearance in radiology. And pneumocystis carinii is very famous for perihilar. Around the hilum, there is involvement seen. Repeating, pneumonia में तो lobe involvement, TB में snowstorm, hazy pattern, and pneumocystis perihilar opacities. You will say, ma'am, if I have to make my decision on the basis of CD4 count and the radiology, what is a more likely thing on which I'll make my decision? For example, they say that the CD4 count is say 200. You say, acha, 200 se kam ja raha hai. I think it is pneumocystis carinii pneumonia. But they say along with that, there is a lobar consolidation. You say, oh, radiology has to be given more importance. What you're seeing in the patient versus what you're just going by numbers. Obviously, ma'am, what I'm seeing in the patient carries more significance. So give radiology anytime more significance over the CD4 count. Repeating, less than 500 में bacteria सोचना, less than 200 में think of pneumocystis carinii pneumonia. So going ahead with the lab diagnosis, I want to tell you what is the screening methodology, and you don't have to learn all these ELISAs, but out of all these enzyme immunoassays or ELISA, at present, it's the 4th generation assay which is said to be the most important screening methodology that we have. Whereas for confirmation, I think everyone is aware that for confirmation, we have the Western blot testing that is there. I know a lot of you have a confusion कि ma'am, for this confirmation, ये जो Western blot करते हैं. So see, I've got you a list of everything. ELISAs are of 5 generations now, but as per all the guidelines, the 4th generation ELISA is going to be our screening test. And as per the confirmation, Western blot is the screening test. So the last thing that you have to know कि Western blot होता क्या है. This is how a Western blot strip looks like. And in this Western blot strip, I realized that there are a lot of GP molecules that are written. Achha, so basically all the HIV GP molecules are being tested over here. Wherever the band will come, वो मतलब positive है. So how many bands should come for me to say that HIV is positive or not? So one definition has been given by WHO, one definition has been given by CDC. Both of them are on the basis of all these GP molecules only. So WHO says if bands are there, antibodies are there against any two envelope proteins. Envelope proteins kaun se the? Ma'am, there was GP160 and GP160 was divided into GP120 and GP41. So any of these envelope proteins, if any two of these come out to be positive, irrespective of others may be there, may not be there, I really don't care, but any two of these come of these GP160, 120, 41 come positive, WHO says that is HIV positive. CDC says that we are giving you a list of 4. Out of those 4, any 2 should be positive. But देखो, out of those 4, 3 तो वही है WHO वाले. 160, 120, 41 वो तो same repeat हुआ. 160, 120, 41. CDC has considered P24 also. So now out of these 4, CDC says that at least 2 bands should be present. So WHO has said that out of these 3, any 2 bands should be there. And CDC says that out of these 4, any 2 bands should be there. So definitely, if I show you this, you will say that, ma'am, ये last वाला स्ट्रिप देखो, इसमें तो none of the bands have come positive, सिर्फ control positive आया है. That means this is a totally negative situation. On the other hand, the first one is almost showing me every band positive, so that is going to be strong positivity. The next one, if I see 160 and 20 में तो आ रहा है, 160 and 120 is coming. 41 is coming very, very weak. Then other molecules are coming like P24. So I can definitely say that this is also positive. So that is how we do the assessment of Western blot, and Western blot is said to be the confirmatory test. So now I want to take you to the last question of HIV which was coming in the exam, and they ask you that someone has undergone a needle stick injury. Needle stick, some healthcare worker, some doctor, some nurse, some intern, someone has undergone a needle stick injury. तो अब कौन सा टेस्ट कराएं? Earliest test that you should be doing. Everyone ended up marking P24 Western blot. P24 karao, because P24 was there in the options. But do you know what is actually the earliest trace? Karo, P24 will rise, okay, but what will rise even before P24 is going to be the HIV RNA in the blood. So if HIV RNA is written, you will select that over P24. Please note, the year that the question came, HIV RNA was not there in the options only. So jab nahi tha, to then I had to select P24 as the answer. But if HIV RNA is written, then I will always select that over P24. Okay, if I go back to retrovirus, I had told all of you that retrovirus mein we have two things. One of them is going to be HIV and the other one is HTLV. So what are the things about HTLV that you have to know? A quick revision that I'll teach you from pathology. Please note, it is human T-cell leukemia lymphoma virus. So break down karo, what will it cause? It will cause leukemia lymphoma. And which leukemia lymphoma, B cell or T cell? Common sense, ma'am, T cell. So remember, it causes ATLL, adult T-cell leukemia lymphoma. Wow, such a simple common sense thing. Human T-cell leukemia lymphoma causes adult T-cell leukemia lymphoma. Via which gene? God has given it a tax gene. That's a previous year exam question. Other than lymphomas, can it cause something else? Yes, it can also cause a non-cancerous thing known as tropical spastic paraparesis. What is the mode of transmission? It can go via blood and body fluids. In fact, breast milk transmission has also been described. Do you remember in pathology what cells were seen? This is important for NEET and INI students. You see the clover leaf cells. The microscopic examination shows you cells which are going to be clover leaf. So if we draw it over here, this is how the cells will look like. The nucleus will have a clover leaf configuration. So that is what you had to know about HTLV1. So the retrovirus family is done, and we have to end our RR with the discussion of the deadly COVID. Trust me, even if you skip it, you're not going to miss out on anything because you already know everything about COVID. So I'll quickly make you scan through COVID in 5 minutes, showing you the basic pathology, microbiology, radiology. Jaldi se let us scan through the 5-6 most important questions. Coronavirus, what should I say about it? Wuhan virus, and I was reading a meme on one of the social media platforms, and like they ask you which travel destination changed your life or which city changed your life. So a person was asked which city transformed your life, and he said Wuhan. That is the impact that this has had on us. So remember, SARS-CoV-2. Coronaviridae is the family. No one will ask you. What they will ask you is the genus, and the genus is the beta coronavirus. Now on that note, this is how the coronavirus looks like. I don't want you to go into all the details. I just want you to see that, yeah, there is a spike protein. Why do I want you to focus on the spike protein? Other than that, there is N antigen, M antigen, E antigen, all of that. ठीक है, नहीं याद करना. Spike protein याद करना है, because even when you look at it under the electron microscope, you will see these projections coming out. That is why the word corona, and the news channels to made like big crowns with jewels on it. That coronavirus is also said to be a crown virus. It looks like a crown. Why does it look like a crown? Because it has petal-like peplomers which are going to be there. Petal-like peplomers are going to be present. So this crown type of appearance is the classical for a coronavirus. Now that petal-like is going to help in attachment. So if someone asks you that these spike proteins, S1 spike protein, S2 spike protein, they are going to come and attach to which receptor of our body? They attach to the ACE2 receptors. But do you know, these spike proteins are little shy. Someone has to give them, introverted hai. Thoda sa spike proteins are introverted. Some extrovert friend will come and will say, acha chalo, let's do some work. Then only this introvert will work. So who is actually going to come and activate this spike protein? We only do that. We are digging our own grave. We have something on our cells called TMPRSS2 that goes and activates the spike protein. That spike protein then attaches to ACE2 receptor. So if I had to write this entire story, what will I say? I will learn that TMPRSS2 is going to go and cause activation of the spike protein, and then this spike protein is going to come and is going to attach to the ACE2 receptors. That is what has been implicated. Now on that note, do I need to tell you this? What are the clinical features? We've been through it, we've seen this, we've experienced it, and no one, we can write long questions on this. Fever, difficulty in breathing, dry cough, shortness of breath, loss of smell, anosmia, all of us had it, loss of taste, it was pathetic. Then later on in the second wave, we also had GI symptoms. Many people had nausea, vomiting. Of course, this is an autocorrect, so there's going to be diarrhea. So we can, as I said, we can definitely take up a million clinical features, and we are all aware of it. I don't think I had to even teach you this. Chalo, for completion, I have taught you. Now I will show you a few radiology pictures. What do you think? Which is the most common radiological finding that you see? We see multifocal ground glass opacities, GGOs. You can see lots and lots of GGOs over here. Yes, we can see multiple ground glass opacities which are marked over here. And yes, beautifully shown. But can there be something else? So when I say ground glass, have you seen ground glass? वो glass होता है which you can't see through also, but it's not entirely opaque, as if glass has been churned. So it's kind of see through, kind of not, because you can kind of see through this. You can see some bronchovascular markings in the behind, and kind of you can't. But when you can't see anything at all, like this is a complete whiteout. When you can't see anything at all, that is going to be a consolidation. So you can see ground glass opacities and you can see consolidation. In fact, you can see one more thing which I want all of you to note. You can see the presence of halo sign and reverse halo sign. I'm teaching you a little bit of radiology here because COVID, everything is important. What is halo sign? That the center is going to have a consolidation and then there is a lighter area around it. Reverse halo sign ulta hai, that the periphery is going to have a consolidation and there is a light area inside. So ye kya lag raha hai? The periphery is having a very, very dark area and then the center is going to be light. What do you think? Halo or reverse halo? This is known as the reverse halo sign. These signs are also known as the atoll signs. Tell me, what is this? The periphery is very, very dark and the center is going to be a little lighter. So these are all reverse halo or atoll signs that are present. Now, finally, the last radiological finding, ma'am, the entire lung has been affected bilaterally. This is known as the crazy pavement pattern, and I have written it in this broken line because ये broken lag रहा है. This is the crazy pavement pattern that you see in case of COVID. So what all could you see? Most commonly you see the presence of ground glass opacities. You can see consolidations. You can see the presence of these halo signs and reverse halo sign or atoll sign, and you can see the crazy pavement pattern. So how are you going to do the diagnosis? For the diagnosis, oh, this is traumatic. Everyone remembers this swab and this vial. So you are going to take one nasopharyngeal swab and we are going to take one oropharyngeal swab, and what are we going to put it into? We will put it into the same vial, and this vial contains VTM. What is this fluid? This fluid is VTM, that is a viral transport media. It has some basic growth factors, some basic things basically to transport the virus, ताकि the virus should not die, vital rahe, the virus should remain vital. It has a little bit of sustainability factors in it. Fine. What test was being done? Of course, ma'am, again, you're taking us into trauma. It is RRT-PCR. What is RRT-PCR? RR matlab, this is number one real-time reverse transcriptase PCR. It is a real trial, reverse transcriptase PCR, and I hope you remember at the end of it, there was a CT value also that was given. What was the CT value? CT value matlab, this is not the CT value of CT scan. This is the CT value that the microbiologist was giving you. This is the CT value of PCR, known as cyclical threshold. Means lower the CT value, it took lesser time to grow the virus. The virus amplified very quickly. So lower the CT value, more was the infectivity. It had an inverse relationship. So if the people who had CT values of 10, 12, they had very bad survival. People who had CT values of 20, 22, we were not worried about them. So lower the CT value, we were very, very worried. Matlab jitna kam CT value, utna zyada infectivity. So if you remember, RRT-PCR ka report said positive, negative. Then they gave you a cyclical threshold. Then they also told you what genes were tested. So the genes that were ENS, E gene, N gene, and S gene, these are semi-confirmatory genes. Whereas the confirmatory genes were RDRP and ORF1. Just remember, at the end of the report, you had to see RDRP and ORF1 because some of the labs were good. They said positive hai ya negative hai, clear cut. Some of the labs said E gene is positive, N gene is positive, but RDRP is negative, ORF is negative. So people could not understand कि हम positive हैं या negative हैं. So which are the confirmatory genes that you have to look out for? You have to look out for RDRP and you have to look out for ORF1 gene. So that is settled. But I don't think we remember this test as much as we remember this. So I've kept the most nostalgic thing for the end, and that is the COVID-19 card test. Like any other card test that I have taught you, it has the same principle. Guys, last time in microbiology that I'm asking you, what is the principle of a card test? I have taught you in malaria chapter, immunochromatography. What does control tell you? Control tells you the validity of the test. So ये test ठीक है, ठीक test करा है. The test line over here will tell you positive or negative. Here, so you are getting a test line. So the report over here, of course, we all detected it as positive. This so we can say first hand because we've done it on each one of us, right? On our patients also, on our cells also. So this was the card test for COVID-19, which is pretty much like the card test of any other infection that you have. On that note, with a smile on my face and probably not on yours because you might feel that virology is tough, and that it is, we have come to an end to virology and also to the end to the rapid review that you had. So bacteria, virus, fungus, parasite, general and immuno, all of it has been covered, and now you just need to listen. Trust me, it's a lot of information that I have condensed in this time duration. Even if you've seen the main videos, you will realize that not a lot of things have been left out. Everything has been very beautifully concised into few slides. So now you need to just go through this again and again and again. Listen to it once and then just keep going through the PDFs and the notes again and again, because the more number of times you go through it, every time you will find a question hidden. That is the beauty of the RR that we have for Path and Micro. So just remember, revision is the game. It's a game of revision. This is one of the recent INI-CET toppers who has told me, and that I am always telling all the students that he told me, ma'am, it's just a game of revision. And I understood that, and that is why he got a rank 5. So please remember, game of revision. Pick up these videos, revise n number of times. That is what you have to do. I hope you found this RR beneficial. All the very best, guys. God bless.